So for my panel discussion, I focused on how EGFR mutant lung cancers develop resistance to the treatment. And this was by Nitin Roper and his fellow colleagues. And we start with the background. So we're focusing on the EGFR mutations, which is also lung cancer. Especially in this article, it's adenocarcinoma, which it doesn't do a great job of explaining. I think that's one of the limitations of the article is, there's 3 different lung cancer types here, but this one focuses on adenocarcinoma. And the treatment option that we're looking at the mechanisms of resistance is osimertinib, which is an oral medication. It's a TKI or a tyrosine kinase inhibitor, so it's inhibiting the uncontrolled cell growth of the lung cancer, which is that EGFR mutation. So we look at our actual experiment, which involves 34 patients with the EGFR mutant advanced lung adenocarcinomas who all took part of this phase 2 clinical trial. And these patients had progressed after previous TKI therapy, so other therapies unlike osimertinib, that were treated with osimertinib. And the study's goal was to assess how osimertinib, how it's a little different, its efficiency, and investigate how local ablative therapy, which is LAT, also might help some of these diseases, like this adenocarcinoma. And we are also focusing on these mechanisms of resistance that's building after we take this trial, after we take these medications like osimertinib. How is it building resistance? And that's kind of how we're focusing, with evolution. So there's the pre-treatment biopsy and surgery were performed to gather kind of the baseline data, and then as treatment options were done, and in a few cases after death, more biopsies and surgeries were done, and we looked at the RNA sequencing to see the insights into the molecular evolution of the resistance of these EGFR mutations. So now, the specific mechanism we're looking at is MET amplification. That's one of the lead mechanisms that we'll see in the results here. We also see gene fusions, and we also see these KRAS mutations. And in this picture, you can kind of see, so we see the MET amplification on the right, and on the left, and that's kind of the main driver, I would say. The KRAS is a smaller amplification, and then you see kind of the EGFR amplification as well. So just a lot of amplifications, a lot of different mechanisms, but we're focusing on these 3, especially with MET. It's kind of the biggest one, and it's kind of just, as we're building resistance, the cancer cells continue to grow, continue to mutate, and it's very uncontrolled. It's obviously patient by patient, but the osimertinib, we're looking at those mechanisms, and those are the 3 biggest ones. So now, some of the results, we see this resistance, at least one mechanism of resistance in 93% of the patients, so 93 out of the 34. And we see 2 or more mechanisms of resistance that coexist and co-evolve together in 73%. Specifically MET amplifications in 66%. So we see a lot. I mean, it's crazy how high these numbers are and just how much resistance is getting built after this clinical trial. And if you look at the figure on the right, so the LAT-001 is just one of the patients. So C is the first trial, and D is the second trial. Different patients, which I think is a bit of a bias or kind of limitation, but you do see in D just how many missense mutations there are. It's almost the whole genome in that area. So tons of missense mutations. You can see some frame shifts, especially on LAT-011. So tons of different, a lot of nonsense mutations as well. So we're seeing a lot of mutations, a lot of resistance being built to this medication, to this oral medication, osimertinib. So now if we look at what's next, this paper provides a lot of insight on the mechanisms of the resistance, especially to osimertinib in lung cancer patients. So we identified the MET amplification, the KRAS mutations, and the gene fusions as some of the common resistance mechanisms. Especially after initial success with osimertinib, we see where it starts to evolve, and we see less success. So, like I said, 73% patients showing multiple resistance mechanisms, which kind of highlights the need for more personalized and combination-based therapies. which is kind of the big thing that needs to come next. So we looked at this with HIV, and it's still a big factor with this, as you know, they evolve very quickly. We need combination therapies, and especially MET, since it was the biggest one, like MET inhibitors, maybe with osimertinib or other therapies too. But if we take, same with HIV, if we take a combination, we can slow down the resistance, which kind of gives patients more time, which would be big, and just trying to slow the resistance to medication any way possible, similar to HIV, with this combination therapy, including osimertinib, which is pretty groundbreaking and is a very good medication with itself. We see a lot of success with it, but there needs to be some sort of combination so it slows down even more. So I thought that was super interesting, combining that with HIV and just seeing how the overlap between a lot of these like mutant diseases, and just seeing how the high percentages I thought was kind of fascinating. Just how quickly and just how many high of a percentage of these patients that were building resistance and had even 2 or 3 mechanisms I thought was wild to see. So that was just a little highlight of the paper and what I found interesting. And hopefully researchers can go from there. And there wasn't too many biases or implications I saw. Like I said, wish it focused on specifically saying which type. It was kind of hard to see that was just adenocarcinoma. It didn't talk about the other 2 types. But yeah, that is my Padlet discussion.